Hi, everyone. My name is Tracy. I'm one of the social workers here, and this is going to be the Transplant and VAD Caregiver Education class. So I am going to go ahead and share my screen, which you should see a PowerPoint presentation um, for the Transplant and VAD Caregiver Education. So a couple of things before we get started for this class. If you are attending this class, you don't need to include your last name when you are attending this group. We want to protect everyone's privacy. If you do include your full name, first and last name, it will be visible to all the participants in this group. So we just prefer for your privacy that you don't enter your last name. This is an online caregiver education class. So if you do have your camera on, other participants will be able to see you and see what you are doing. Also of note, the caregiver plan. So in order to get credit for attending this class, you will need to complete the caregiver plan form. It is very important to complete this to get credit for attending this class. We don't take any kind of attendance. I can't draw anyone's name to say like you attended this class. You must complete the caregiver plan form to get credit for attending this class. I do go through at the very end of this class about what the form looks like, how to complete it, and where to send it. So let's talk a little bit about why we have this class. We want to make sure that you understand why a caregiver is needed, understand what is needed and how vital your role is to the success of your loved one's transplant or VAD implant. So VAD stands for ventricular assist device, which is for heart patients. So I'll be talking about that. And being a caregiver for transplant is much different than being a caregiver in other circumstances because this is more than just, going in and checking up on someone a couple of times a day or anything like that. You're going to be with this patient 24/7 for a period of time. Making sure that you understand the timing of the transplant needs and program requirements. Making sure that you guys know how to find help when you need it. And then equally of important is making sure that you're caring for yourselves during this difficult time. So why is a caregiver needed for transplant? Well, as you can see, research has clearly shown that patients with supportive caregivers are more likely to be successful with their transplant and ventricular assist device implantation. So what does that kind of look like? Well, when patients are more successful with their transplant, they are attending their appointments on time, they're eating the right foods, they're exercising like they should, they're taking their meds like they should, picking up their medications up on time. And then when they don't have that sufficient support, the transplant staff routinely see major difficulties for these patients. And those look like the exact opposite of what I just said. So patients don't show up to their appointments or they show up late. They're not exercising like they should. They might not be eating the right foods. They're not eating nutritionally. They don't take their meds on time. They might not be taking them at all, or they're taking them, or they're forgetting to get them filled in time. And when that happens, unfortunately, all of those, if those things are happening, it can lead to rejection of that organ. And when patients go into rejection, it can be much harder to get a retransplant, if at all even possible, when patients don't have shown that they don't have that sufficient support. So what are the basic minimum qualifications to be a caregiver? You have to be at least 18 years old, the ability to drive in the Jacksonville area with a valid driver's license and have a reliable vehicle to use. Now, if you do not drive, that is a conversation you do need to have with your primary social worker so that you can have a sufficient transportation plan. Because if you're planning on using like a hotel shuttle, those only run at certain times of the day. So some of them only run from like 7 a.m. to 5 p.m. and you can be here as early as 6:30 for lab work. You can be here as late as like 6:30 at night because of like appointments, because certain departments can be open later, like imaging here at Mayo Clinic. So what is that going to look like for you in terms of that transportation as a caregiver? If you are driving, please make sure that you have a valid driver's license because we don't want you to get pulled over and then have the patient and you be stuck. And then also, of course, being able to use a reliable vehicle that works. The ability to take adequate time off of work. So, if you are working as a caregiver, you are not able to leave our patients and go to work. So, you can't leave our patients to go to work for an hour, for 2 hours, 4 hours, 6 hours, 8, 10, 12, whatever your schedule is. You cannot leave our patients to go to work. So, do you have that ability to take time off of work? Are you using FMLA, which is family medical leave? Now, that's not necessarily paid. So, do you have like paid time off? All of those things. If you are working remotely, I do have some caregivers that have an ability to still work remotely, but you can't again leave the patient to go to work. You're going to have to be here at Mayo Clinic for appointments and participating in appointments. So depending on what that work schedule looks like for you, sometimes it's not always possible. I've had caregivers tell me I have to be at my desk from 8 to 4:30. So that likely wouldn't be possible for most people, but I do have some people that can work a little bit remotely with a flexible schedule. And then from other responsibilities, such as like caregiver duties. So if you are a caregiver of minor children, which is anyone under the age of 18, or any other adult, you are not able to caregive for anyone else and be a caregiver for our patients at the same time, because this is like a full-time job. I've never had a caregiver come back at me and tell me, "Hey, Tracy, that was a lot easier than you said it would be." So we don't want you to have to worry about how am I going to pick up kids from school, or having to manage, a child's schedule, like even just, their day-to-day activities outside of school, or like other adults, like how are, trying to manage their own schedules, appointments, things like that. So when we do meet in the outpatient setting, we often talk about who is going to manage that care on your behalf if you're not able to do it. So, who will be taking care of the children? Is it the other parent? Is it other family members, friends? And the same thing for any other adult. And then, of course, being comfortable handling the patient's medications and doing some minor medical care after training. So, part of the reason you're going to be in the hospital the majority of the day is that you're going to be learning all of these things. So, it's not just like a one and done teach, it's an ongoing thing while the patient is in the hospital. So, we'd like caregivers to be present for as many of the evaluation appointments as possible and to be present for that social work assessment, because you need the education provided by each member of the team. So each member of the team, so when you think about that, the dietitian, doctors, surgeons, all of those people have what we call like a piece of the pie. So they're all providing education to you as a caregiver about what to expect, not only post-transplant, but also pre-transplant as well. And it's really important for you as caregivers to be hearing that information directly from the source. And also, sometimes patients can be obviously very sick coming into transplant. Their concentration levels wax and wane. So they don't always hear information like they might normally would if you were healthy. They may miss pieces of information, and also they may need help giving information as well. And that's why we like to have that caregiver there. It also shows a level of commitment on the caregiver's part as well. And we do want the caregivers to be present for each update appointment, like appointments with the physicians, nurse coordinators, and social workers. Update appointments can happen from every 6 months to a year to every 2 years, depending on what's going on. Obviously, a lot can change in that time period. And so we like to meet with patients and their caregivers to get an idea of how things are going, what's changed. I also find that caregivers have had time to sit on information. So sometimes they'll come in with further questions about what's been going on. The other piece to know is obviously hearing that information again is always a good thing too, because repetition is key. Sometimes the patient's condition may decline while they wait for transplant, which does require the need for a full-time caregiver. And this is determined on a case-by-case basis by the medical team. So this is not for everyone, but this is where a patient's condition has deteriorated in such a way that they are no longer able to be by themselves, and they need to have someone with them 24/7. So what will that look like if that were to happen? So when I meet with patients in the outpatient setting, I talk about this. If this were to happen, what will it look like? Not because I'm looking for a specific answer at that moment, but because I want people to think about it. I have seen it happen before. A patient's condition has gotten worse to the point where they no longer can be by themselves. And the team isn't going to continue to move forward with transplant unless this criteria gets met. So we need to have that caregiver plan in place pre-transplant as well. Again, it's a case-by-case basis, so not for everyone, but I do encourage people to think about it in case it ever happens. Any changes to the caregiver plan or financial changes should be communicated to your transplant social worker immediately. I know that no one wants to say anything that might upend the listing status, but these are two very important components to the plan. If a patient comes to the hospital by themselves or with a change in your caregiver plan and the medical team is concerned, they may not move forward with transplant, and I have seen it happen before. So I've had patients come into the hospital by themselves. They don't have a caregiver with them. And I have had them show up with a change in their caregiver plan and the medical team is concerned. And so they haven't moved forward with transplant. I do understand that life happens and things can change and your caregiver plan may change and that's okay, but you do need to inform your social worker. That social worker needs to speak with all the caregivers and that plan so that we can make sure we always have a solid plan in place for people. The other thing to know is financial changes. So I do understand that financial changes can happen. Sometimes people, their like living situation changes, their job changes, that can change your financial status, right? It can change your income, it can change your insurance. Those are all really important components to the plan. We always want to make sure that people can afford any relocation costs if it's there, they can afford their medications. And when insurance changes happen, that can change a lot of things. Some insurances have a relocation reimbursement, but not everyone does. So maybe you had an insurance that had a relocation reimbursement, but it no longer does. How are you going to afford that time that you have to stay here in Jacksonville? Changing your insurance can change your medication costs. So we always want to make sure that we're aware of any of these changes and we always have a solid plan in place. The other thing to note is that Mayo Clinic is not in network with every single insurance. So we want to make sure that we're aware of any insurance changes so that if a prior authorization has to be put in place, that those things are being done. Who are members of your transplant team? Well, they include, of course, the surgeon who does the surgery, the physician who's overseeing your transplant care, along with the advanced practitioners and the nurse coordinators who are also helping to oversee transplant care. Pharmacist manages your medications. Social worker does your psychosocial plan. So caregiver, financial plan, relocation, pharmacy. Financial coordinator does your insurance. Dietitian manages your nutrition. Transplant psychiatrist or psychologist manages your mental health. Palliative care team manages your quality of life. Schedulers and other medical support staff. These are all members of your team. You may not necessarily see every single member, but they are there for you. So for example, I may not have seen the psychiatrist, but maybe I'm waiting a year or two on the transplant list. I'm becoming more depressed or anxious, and maybe the social worker, the medical team, or you as a caregiver think that the patient needs to see the psychiatrist. Those are not bad things. These team members are there to help support the patient, which in turn helps support you as a caregiver as well. This is pre-transplant relocation, which is different than post-transplant relocation, which we'll go into down the line. But this is required for some patients prior to transplant to avoid the cold ischemic time for the donated organ. That is how long the organ can be out of the body for. If you are required to relocate, you are asked to stay within close proximity to Mayo Clinic and your team will provide those specifics. And you may be asked to have a caregiver relocate with you. So I'm going to go on to the next slide, which does talk about what those requirements are. So as you can see for heart, it's 3 to 5 hours as determined by the team. Kidney and pancreas do not have any pre-transplant relocation. Liver is about 9 hours, lung is 6 hours, And VAD, ventricular assist device, is not required because that's a scheduled surgery. These are considered general guidelines. So for example, like if I live in the state of Montana and I need a lung transplant, I'm going to need to move within that 6 hours time frame in order to be actively listed. Now, sometimes patients are able to come and stay locally by themselves. They're relatively okay. Sometimes the team may say your condition, your health is too deteriorated. You need to have a caregiver stay with you. If you do come by yourself, just know that you may be asked to have a caregiver come in down the line as well, and that's okay. Now the team can ask you to be closer if necessary. So sometimes I may live within these guidelines, but something is going on. The team can ask me to stay closer so they can keep a better eye on me, and that's okay too. So let's talk about the call. Patients are given about 4 to 9 hours to get here, depending on the organ. Each organ offer is different, so we ask that you pay careful attention to the instructions given to you by the coordinator. The team is well aware of where the patient lives when they make that call. So, and that call will come at any time of day, by the way. It can come at 10 o'clock in the morning, 2 o'clock in the afternoon, 2:30 in the morning, so any time of day. It will not necessarily come from a Mayo Clinic phone number, so just be aware of that. Make sure that patients keep their phones on them in a way that they can hear it at all times. We have a tendency sometimes to turn our phones down at like bedtime, with work, church meetings, things like that, but you want to make sure you keep the phone on in a way that you can hear it at all times. When they call the patient, they will give them instructions about where to go. So some patients go to the emergency room, some patients will be directly admitted to the floor. It does vary across the board, and that's okay. So that's why you want to be careful. And of course, we want you to be ready and travel safely. In that social work packet, there is a suggested to go list, like a packing list. I highly encourage you guys as caregivers to look at it as well. It does kind of give you some ideas of what you might want to keep in a to-go bag. Dry runs. So dry runs occur when your loved one is called in for an organ, but transplant does not happen, which is usually due to the condition of the donated organ. So if they will call me and say, hey, Miss Tracy, we have this organ for you. While they bring me in, they are still working that organ up to make sure it is viable. And then they'll come into my hospital room and say, hey, Miss Tracy, we couldn't use the organ, and they send me home. That is called a dry run. Their dry runs are never done on purpose. They're not practice or test runs. We're not testing you to make sure you get here in time as a patient and caregiver. When we make an organ offer, we firmly believe there's an offer available, but because of how long that organ can be out of the body for, and making sure that everyone is healthy for transplant, we have to bring people in. Obviously, it can be a lot of mixed emotions with dry runs, anger, sadness, disappointment, but please know that we want to make sure we put in a good working, healthy organ into a person. I do have patients that have multiple dry runs and some that have never had a dry run, so it does kind of vary across the board. So what is a VAD? A VAD is a ventricular assist device, which is an implanted mechanical pump for a patient's heart. When patients get these, it can be kind of because of one of three things. It's considered a bridge to transplant. So a patient is obviously very sick. They need this to continue on to that journey with transplant. It can be a bridge to a transplant decision. So maybe the patient and or the medical team are kind of making some decisions about the patient's ability, to decide on a transplant. And then it can be considered destination therapy, which is usually when a patient is not a transplant candidate at this time. So the hospital stay for a VAD, though, is usually longer. It's actually about 2 weeks. And during this time, the patient and caregiver do get training for wound care and daily sterile dressing changes, which is really important because remember, it's an implanted mechanical pump. You'll also learn during this time about how to manage the VAD equipment, so the alarms that might go off. Also, like during this time, you'll learn about emergency management, so batteries, hurricane resources, and 911 calls and usually about notifying your local EMS. And then there's also a home safety checklist that they go over as well. There are 2 outings that are scheduled to increase your comfort level during this time. One is usually with a nurse and one is without. Multiple caregivers must be educated during this time because this is a lifetime commitment by people. Let's talk about admission. During this time, the caregiver's role is crucial, and you should be with the patient when they are admitted for transplant, if at all possible. Remember what I said earlier about the change in caregiver plan or the patient coming by themselves. So if for some reason the patient is coming by themselves, that is something you do need to discuss with the medical team and get some special permission for. Um, some patients, the primary caregiver may live further away. So my patient could live here in Jacksonville, but maybe as a primary caregiver, I live up in the state of New York. Sometimes people come in with their backup caregiver until the primary is able to get here. But those are all things that need to be discussed with your team prior to the transplant so that people are aware of that plan. You need to be in the hospital the greater part of the day shift each day of the hospitalization. So think 8 to 10 hours a day. So like 8 to 5, 9 to 5, something like that, but it is daytime hours. You may sleep in the room if you are able to rest there, or you can arrange other accommodations. I do not encourage my caregivers to sleep in the room because I really believe it is important for you to get rest. But sometimes for a variety of reasons, it's not always possible. Sometimes the patient and or caregiver feel better being in the room. They know what's going on. Sometimes it's a financial point that people are saving their money for discharge, which is understandable. So, I do understand that. During this time, you are providing that emotional support. So you're their cheerleader. You're encouraging the patient to do things even when they don't want to, which it could include like doing their exercises in the room, exercising multiple times a day, eating foods, things like that. Taking their medication. During the time that you're in the hospital, the nurses will teach you and the patient about medications, monitoring vital signs, and other post-hospital care. So again, it's not like a one and done teach for patients and caregivers. It's an ongoing thing so that you can have a solid understanding of it once you get closer to discharge. What happens in the hospital? During this time, the physician assistants, and nurse practitioners do round daily, usually in the morning, and monitor the patient closely. This is a great time for you to have that one-on-one time with the medical team. So they're there for you. They need your input. You can get your questions answered, address any concerns. You're with the patient the majority of the day, so you see things we don't necessarily see. The bedside nurse and an inpatient nurse coordinator do provide education on medications, wound care, testing blood sugar, and insulin injections if needed. So again, this is why you are there every day during the day to learn all of these things. The inpatient nurse coordinator will obtain the medications from the specialty pharmacy that the patient selected and provide you with the schedule of your outpatient appointments. So in that social work appointment, the patient was asked to register with a specialty pharmacy, and the nurse coordinator will have those medications delivered here to the hospital, and they use them for all of the teaching purposes. The inpatient transplant social worker assists with unexpected issue and day-to-day stress. So in that outpatient setting, you have an outpatient social worker. They assist you with developing that psychosocial plan. In the inpatient setting, you'll have a different social worker. They make sure that the plan you developed is still in place, address any changes, and are there to provide support not only to the patient, but to you as a caregiver as well. And then there's also a case manager to assist with unexpected issues and discharge planning, by the way, for equipment or home health care if needed. So like if you need a cane or a walker or home care setup. How long am I going to be in the hospital for? Which is a generally good question. A heart is about 7 to 14 days, and that ventricular assist device is about 14 days. Kidney is about 2 to 3 days. Kidney pancreas is about 5 to 10 days. Liver is about 4 to 7 days. And a lung is about 7 to 21 days. These are considered average lengths of stay, and so the patient can certainly have a shorter or longer length of stay depending on their hospital course. Some things to think about as you get closer to discharge from the hospital. So a day or two before discharge, you may want to think about making sure that the home the patient is returning to is clean. That infection control is very important. So they take these anti-rejection drugs, which suppress their immune system. So it makes to prevent that rejection from occurring. And then in turn, it makes them more susceptible to cold infections, the flu. Doing any grocery shopping or meal preparation, bringing those patients' medications to town and have them available. So that would be like their old medications, because remember, they're going to get those new medications here in the hospital. And moving into and setting up any hotel or rental space that needs to be arranged. In that social work packet, there is an accommodations guide that has a list of hotels in the area. A lot of people who look at a hotel post-transplant look at a suite because you can cook and store food there. There is also our hospitality houses on campus. There is Gabriel House of Care, which is for transplant and cancer patients only. It is $55 for the first night, $40 each night after. It is for patients and their caregiver. You get a room with 2 queen beds in your own bathroom. There is no eating or drinking in the room per their policy, but they do have a very big communal kitchen and living area, so you can cook and store food. And they also offer free Wi-Fi as well, by the way. It's very nice. And then there's also for the liver patients, if your diagnosis is related to liver cancer, you have the option of Hope Lodge, which is for cancer patients only. It is next door to Gabriel House of Care. It is free. They do also, you get a room with your own bathroom. They also have a very big communal kitchen and living area as well. And then finally, I have a lot of patients that utilize Airbnb and VRBOs as well. Everything I just kind of listed off is first come, first serve. So I do encourage you to have multiple options, do your research, think about where you want to stay, what's available, those kinds of things. Backup caregiver. So we do understand that life can happen, and sometimes the primary caregiver is not always able to be here at the time of transplant. So it is a requirement to have at least one backup caregiver. They are considered on call. They do not need to be present if the primary caregiver is here. However, if the primary caregiver is not able to come, the backup caregiver will be asked to come immediately. So again, the backup caregiver does not need to be present, but if something happens to the primary caregiver, they must be willing to come immediately. So if I speak to a backup caregiver and they're like, hey, Tracy, I need 2 weeks notice, I can't guarantee that will happen. I've seen a lot of life circumstances happen. I had a caregiver one time, unfortunately, break their leg on the first day. People get sick, emergencies happen. So we need someone who is willing to come immediately. We want to make sure that the backup caregiver is always educated about the role and notify your social worker of any change in the plan. I do encourage backup caregivers to take this class so that they also have a solid understanding about the role. What are going to be some of the caregiver's responsibilities after hospital discharge? Well, you'll be managing all of the medications and managing all of the patient's appointments. They're not going to be able to drive after transplant. So as a caregiver, you will be having to do all of the driving, doing all of the food preparation. So remember, this is very important to prevent any kind of infection. Food has to be cooked through, no buffets after transplant. They go through all of this education with you as well in the hospital. Some patients will have showering, shaving, and dressing assistance. Now that assistance can vary to just stand outside the door in case I need help to hands-on assistance. And of course, you could be providing that medical care, which can include things like an insulin shot, administering medications, wound care, and IV antibiotics if needed. What are some questions I get from caregivers about this role? Can the recipient pay for a caregiver? Yes, if funds are not available, the amount will be added to the patient's fundraising goal. I will say that certain There may be some situations in which this is not allowed. That's dependent kind of on the organ. So this is a question you do need to speak to your social worker about. Your primary social worker about, I should say. Does recipient's insurance pay or reimburse me as a caregiver? No, insurance does not cover custodial care, which is much different than home health care. So they won't pay for someone to be there 24/7, but a lot of insurances will pay for like a home health care if the patient qualifies, which is someone that might come out like once or twice a week at, to provide certain services. Can the recipient get his or her care in a skilled nursing facility? No, unless there are severe complications. So that's not something we will plan on ahead of time. Who will complete FMLA paperwork? So FMLA is that family medical leave paperwork, and you get that from your employer. We do not have that here. In the inpatient setting, the inpatient transplant social workers will coordinate having the medical team complete this. Please bring this on day one, because if you wait a day or two prior to discharge, I cannot guarantee it will get completed. And then you'll have to wait until the outpatient setting where the post nurse coordinator will work on getting that completed. So we talked a little bit about pre-transplant relocation, but let's talk about post-transplant relocation. So if you don't live in the Jacksonville area, you are going to have to stay here during that time. How far away you can be from Mayo Clinic depends on the organ, so you can reach out to your primary social worker. But for heart, you're going to be here for about 2 to 3 months, along with as a VAD, it will be 2 to 3 months. Kidney is about 3 to 4 weeks. Kidney pancreas is about 4 to 6 weeks. Liver is about 4 to 6 weeks, and lung is 3 to 4 months. Now, these are average lengths of stay. And so every patient situation is different. And so you can certainly have a longer or shorter length of stay depending on your hospital course. So what will post-clinic discharge follow-up look like? Patients can have clinic appointments 2 to 5 times a week. Those appointment times can vary. You can be here all day or just have a couple of appointments. But as a caregiver, you are required to attend every appointment with them and do all of the teaching with them. You're that point of contact between them and the care team. The patient will be getting frequent lab work. They can get lab work as much as weekly, if not more. Patients are not able to drive until cleared by the medical team. It is important for caregivers to stay on top of all medication changes and to ask questions, because patients get that lab work quite frequently, and that may require very frequent medication changes. And you can't necessarily go by what's on the bottle, because if I, as a patient, get told, like if I'm taking 1 milligram twice a day and now they're having me take 2 milligrams twice a day, what I'm taking is not necessarily what's written on the bottle. So you have to be writing things down and keeping very good track of this, not just by going like lining up the bottles in a row. As I said earlier, you attend every appointment with the patient. In that hospital setting, you are going to get a binder of information. That binder has information about keeping track of their medications, how to monitor their vital signs, and taking notes about everything so that you can show the medical team so that you have a solid understanding about everything. And the medical team can also review that information to make sure that nothing is going on with the patient. Heart, VAD, and lung patients will attend a 12-week cardiopulmonary program when cleared by the medical team. It's usually 3 days a week. If the patient gives you access, you can access their patient portal. It allows you to receive up-to-date information about like their appointments, their test results, physician notes, lab work, and then it also allows you to communicate with the care team, which is really nice. So when you talk about going home, it's not uncommon for patients and caregivers to feel a little uneasy, but you have a coordinator and an entire medical team to help guide you. Remember that there is always someone on call to assist 24 hours a day, 7 days a week, and you will find that information about how to contact the on-call person in that binder that's given to you. Remember to communicate any changes, problems, or concerns to the medical team. During the time that you're in the Jacksonville area and even afterwards, the patient does come back at regular intervals as scheduled by the team. Attend support group, which I'll go through here in a minute, and the patient should become more independent as their health improves. So we teach you as a caregiver with the idea that you're going to teach the patient. What are some things to think about from a caregiver standpoint? So, are you going to have to relocate pre or post transplant? And what does that look like for you? What about your own home? Do you have family, children? Are you caretaking for anyone else? What about your job? What about pets? Those kinds of things. Extended time off of work. So, are you using FMLA? Are you taking paid or unpaid time off? If you're taking unpaid time off, how are your bills being paid? I don't ask these questions to be nosy, but because I want you to think about what that will look like for you and to help avoid any unnecessary financial stress. So, if we can make sure we have a solid plan for the patient, but also for you as a caregiver as well, because we can't have you showing up to the hospital and being like, hey, I have to go to work. Feeling overwhelmed by requirements and patient's condition and or behaviors. So it's not uncommon for people to caregivers. This isn't like your first time being a caregiver and you've been doing this for a while. And you're going through this process, and it is a process. And so sometimes it gets to be a lot, right? And you've been working with the patient for, it could be years. And so sometimes that can lead to being burned out. So what are some signs of caregiver burnout? Well, it looks like sleep or appetite problems. So maybe you're having difficulty falling asleep, staying asleep. You're not eating healthy. Maybe you just don't have an appetite, so you're losing a lot of weight, feeling that utter feeling of exhaustion. So being more fatigued, being more irritable, short-tempered, you say things sharper than you normally would. You're neglecting your self-care, which can include like, I'm not going to my own medical appointments. And I'm also not doing things that I do to de-stress. So we all have things we do to de-stress, right? So some people go to the gym, some people go for a walk, some people spend time with their friends, go to lunch. And we have a tendency when we're caregiving, of course, those things fall to the wayside. And I'm being more depressed or anxious. So if you read that and think, wow, Tracy, I'm thinking about some of those things, what can I do? It is important to know that it is not selfish to take care of yourself, and we can't take care of anyone else if we're not taking care of ourselves. So very important to take care of yourself. So getting enough sleep and exercising. Exercising really does help. And asking for help. So this is often difficult for people because I often hear like, Tracy, I don't want to bother anyone else. They have their own lives. But this is why we do have a backup caregiver in place. And sometimes help comes in the form of different things. It could be someone that's just helping you with like cooking or cleaning, because I've had caregivers say like that was really helpful. Keeping your own medical appointments. So you do have to take care of yourself. Support groups. So like every support group has a support group for patients and caregivers, which is held by Zoom and is sent to the link for that support group is sent to the patient's portal. So Heart has a support group every Tuesday at 1 p.m. for Heart and VAD. Lung has a support group every Tuesday at 1 p.m. Liver has a support group every Tuesday at 11 a.m. And Kidney has a support group for the fourth Wednesday of every month from 2 to 3. Again, that link is sent to the patient's portal, but you as a caregiver can attend. And then caregiver support group every Thursday at 11 o'clock via Zoom. And I'm going to go through that in a minute further. But remember that you are doing things for yourself. So we talked a little bit about that self-care. So what does that look like for you? Is it reading? Is it taking time out for yourself? It's like in the morning, I'm going to go sit on my porch with a cup of coffee, watching a movie. Is it music, meditation, the gym, running, going for a walk on the beach, or some other spiritual practice? But what does that look like for you? And then also we do have support group every Thursday from 11 to 12 for caregivers only. Patients are not allowed to attend. And you can get the link for that by either emailing one of the facilitators, Eric Prusler, at Prusler, which is spelled P as in Paul, R-E-U, S as in Sam, L-E-R, .Eric, E-R-I-C as in cat, at mayo.edu. Or you can certainly give him a call at 904-956-3085. Remember that you are not alone. Please do not hesitate to contact your nurse coordinator if you have any medical concerns or your social worker for any other assistance. We do also have chaplain services available. So if you have any like spiritual needs, please contact them at 904-953-2000 and ask for the on-call chaplain. We also have Humanities and Medicine, which is a department here that helps with activities while patients are in the hospital. So they have different music, different arts, things like that. And their phone number is 904-953-2058. And the Meditation Island, if you want someplace quiet to go, which is outside our front entrance, or the meditation room in the candidate building. It's not uncommon. So these are some caregiver tips and tricks that other caregivers have said that they have found to be helpful. So prioritizing and making lists. So I like to make lists. It helps me remember things. I like to cross things off. But it also kind of gives me an idea of like, you can write everything down, but what do I need to get done versus what I want to get done? So prioritizing that can be helpful. Make sure that you are setting realistic goals for yourself, and we don't want anyone caregivers trying to set themselves up for failure. You want to be the very best, and that we understand that, but don't set anything up that's unrealistic. Of course, keeping your sense of humor. So sometimes we just need to laugh about things, which can be, you might think like, oh, I shouldn't be laughing about this, but our sense of humor is very important. Establishing a daily routine. So when you think about the appointments, the meal times, the medications, but also it gives you a time to incorporate that self-care. Finding an efficient way to communicate information and updates to friends and family. So sometimes caregivers have said, they become very focused, obviously, on learning everything. And then they get people because they love the patient and they want to know what's going on. And it can become a lot to update everyone. So sometimes people will I'm going to identify two family members and then they're going to be responsible to disseminate the information. They use Caring Bridge. There's social media sites like Facebook. There's, other avenues to do that with. So some common patient issues that can be seen both pre and sometimes post-transplant. So patients are coping with a chronic illness. So while transplant is actually not considered a cure, it is meant to improve patients' quality of life. And so patients have been dealing obviously with this for quite some time. The medication side effects, obviously that happens both pre and post-transplant. And while we do provide a lot of education, sometimes side effects vary from patient to patient. Patients can have mood swings, hallucinations, difficulty sleeping or eating. That can happen both, again, pre and post-transplant, those mental health concerns. Sometimes because pre-transplant patients are waiting for such a long time or even short time. And then post-transplant, they're on these high doses of medications, and it can cause people to experience these things. But we'll talk with you guys about it. We encourage you to talk with your medical team, reach out to your social worker so that we can help you. Some patients recover quickly while others need more time, and don't compare your patients to others. So I hear this a lot. So people will see someone in the clinic setting and they're like, oh, Tracy, they got discharged after me and they're doing so much better. But I also remind people that like everyone's journey is unique. So what works for one patient doesn't always work for another. End of life discussions and thoughts. So patients are undergoing a major surgery, and sometimes caregivers or patients want to talk about these things. And sometimes people are like, oh, that's bad luck, or I don't want to talk about it. But it helps people. It's not uncommon and is normal to want to talk about those things. Patients can feel like a burden. So again, I hear this quite frequently too, like Tracy, I don't want to bother anyone. My family has their own lives. And then, of course, the role changes that happen. So going into this, so whether you're a spouse, a partner, a significant other, family, friend, and then going into being that caregiver role, it does change a dynamic. And then even trying to get out of that role after transplant can be hard as well. So that's why we have these support groups. That's why you have a social worker. Any questions? So we do have a lot of transplant social workers, and you're going to need to know the name of your social worker for that caregiver plan form. So if you don't have it, please write it down. Now, so these are the primary social workers. So you may have seen a different social worker, and that's okay. But these are the primary social workers for that service. So Jennifer Kittinger is the heart social worker. Her number is 904 956-3269. Pat Dennis is Jeanette Davenport and Lakea Butts are the kidney social workers. You only need to write down one name, and that's 904-956-3292. Bob Goodholm is actually a cystic fibrosis social worker. And Sally Blackwell is the liver transplant social worker at 904-956-3205. And Rachel Remlinger is also a liver transplant social worker at 904-956-3208. Bea Flores is a lung transplant social worker at 904-956-3370. Patricia and Tracy right here are actually the two inpatient transplant social workers, and you'll get their information when you're here in the hospital for transplant. And then we also have part-time and float social workers. So we cover for other people when they're off or need extra assistance. So that's Nancy, Maria, myself, Christina, Ashley, Eric, Perrin, and Joya. And you might see these people. You may have seen them for your initial assessment, but we cover. Remember, if your availability, willingness, or ability changes, please contact your social worker right away. It is critical that your loved one has a caregiver needed for transplant, and we want to assist in developing a new plan. I can never thank caregivers enough for what you do. Your role is very critical to the success of your loved one's transplant or bad implantation. They would never make it through this process without you guys. You're appreciated more than you could know for what you're doing for our patients. This is the caregiver plan form. This is what it looks like. You should have received it. So if you didn't, I would encourage you to look at the email because it's an attachment in the email oftentimes. It may also be in the social work folder or the caregiver plan folder if you received one of those. But please make sure you put the patient name and date of birth. If you don't know their Mayo Clinic number, it is okay, but you need to put in their birth date, who that social worker was, type of transplant. You would check that you attended caregiver class and then read this. Put if you have questions or concerns, any comments, you would sign it and return it. Now, how do you return it? You can return it by mail, you can return it by fax, or by email, or through the patient portal. This is that information for how to do that. These are some other resources for you guys as caregivers. If you are looking for additional information on caregiving and assistance with that through Caring Bridge, American Heart Association, on self-care. So this is some further information for you too. All right, and that is all the information we have. Please, please, please make sure that you are returning that caregiver plan form so that you get credit for attending this class. And if you have any further questions or concerns, please do not hesitate to reach out to your social worker. Thank you for attending.